The next talk is on advances in the management of NASH, and the lecture will be delivered by Dr. Farhan Ali, who is Associate Professor of Medicine at Capital Hospital, Islamabad.
Thank you very much. So my learning objects are, these are the whatever NASH, understanding of the pathophysiology and the risk factors, the diagnostic tools, implements, evidence-based treatment. So basically the NASH is the term derived in 1980, and then that there is a change in this terminology from non-alcoholic fatty liver disease in 2002, and then now this is the metabolic dysfunction associated fatty liver disease in 2020. So NASH was first composed by a Dr. Ludwig 3 decades ago to describe as a fatty changes with inflammation. That's a lobular hepatitis in the absence of a history of alcoholism. So we can appreciate here is the histological pictures, normal, there is no fat depositions, there is a simple hepatosteatosis, and there is a NASH. So when there is a deposition of a fat more than 5%, the textural changes will occur, and that leads to a steatosis. Or this inflammation convert into the non-alcoholic steatotic hepatitis, then there is a inflammation. In 2020, this is the changes in the name due to elimination of a steatohepatitis allows for more liberal of a alcohol use. So here is basically the graphic, the changes. So first we can appreciate is the greater than 5% fats deposition, then condition is the fatty liver disease, then there is a convert into the NASH, and then in the NASH we should appreciate this is the early fibrosis, fibrotic changes, or there is a cirrhosis, and these cirrhotic changes convert into a hepatocellular carcinoma. So we should know the classification and the other factors associated with this disease. So the first we differentiate, this is the primary in origin or this is secondary. For the secondary disease, you should rule out the other causes like autoimmune hepatitis, hemochromatosis, celiac disease, Wilson's, hypopituitarism, starvation, or iron errors of metabolism. So spectrum. So here is the normal liver, then there is a fatty liver greater than 5% fats deposition, then the NASH, and there is cirrhosis, and which leads to a hepatocellular carcinoma. So what is the epidemiology and the risk factor prevalence of this disease? So obesity and the diabetes is the major problems nowadays, which is in the background of this disease in over setups. So globally, this is the problems. Obesity prevalence map shows the globally diabetes is involved all over the countries globally, but in the Pakistan, this is in the we are on the ranking in the third in the prevalence. That's the Pakistan is on the top country with the diabetes. So the high carbohydrates, fat, and the low proteins are major responsibilities in the progression of this disease. So 55% have non-alcoholic fatty liver disease, that's convert into a 37% convert into NASH, and then 17% convert into the fibrosis, and that leads to the hepatocellular carcinoma. So this is basically that fatty liver disease is not only the disease of liver. Due to the fats depositions, there is a multi-organs involvement. Liver involvement, then the cardiovascular involvement, and there is also the renal involvement, which leads to multiple complications. So this is a multi-organ disease. So we need a multidisciplinary approach. When there is adipose tissues, abnormal adipose tissues, the pancreas also involved, GIT tract also involved, the liver also involved, and this leads to multiple problems. So when there's a cardiac involvement, the cardiovascular involvement leads to multiple issues in the form of a cardiac arrhythmias, heart failures, or when there's a renal involvement due to the fatty fats, this leads to a kidney failure. So pathogenesis, high calorie intake, saturated fat intake, high fructose intake, and sedentary lifestyles, all these are the basically risk factor which leads to this condition. So another is one of the genes which also responsible in the familiar or the family history which leads to this condition. So those patients which are suffering from the diabetes or in the pre-diabetes, you should work for this disease irrespective of our liver functions. So there is a natural history of disease. So the first there is a cirrhosis. This leads to 8 to 13 years of this conversion. So this is the steatosis that convert into the NASH. There's an inflammation, and that's of 5 to 10% convert to the advanced fibrosis. And these 0 to 50% convert into cirrhosis, and that's out of these 7 convert into HCs. So this is a circle which we can appreciate here. This is a natural history, 8 to 13 years. So those patients with the diabetes have a history of more than 10 years. You should work up for these patients. So the grading, again, is the grading which is very important to assess the severity of the disease. So the stage, fibrosis stage 1, fibrosis stage 2, 3, depending upon this is by the elastography or with the histological assessment. So in the 5F1, there's a stage, there's the perisinusoidal fibrosis, in sinusoidal fibrosis with portal fibrosis. In stage 3, there is a combination with bridging fibrosis and leads in the fibrosis, and the stage 4 convert into the cirrhosis. So another severity, we can assess the severity with its the staging with its NFLD severity criteria. This is the A0 to A2, F0 to F2 is that's the mild condition, while significance is greater than A. This is the activity greater than 2, or F greater than fibrosis greater than 2 phases. So how will you diagnose anyone criteria positive suspecting this disease? So we should assess the patients if the BMI for the Asians is more than 23, or waist circumstances 94 centimeter in the male or 80 centimeter for the females. Fasting glucose greater than 5.6 or 100 milligram, or there is a HbA1c greater than 5.7. This is another criteria. Blood pressure greater than 130/80, triglyceride greater than 150 milligram, or HDL less than 40 milligrams. So these criteria should be assessed and work up for the fatty liver disease. So the best area to assess the belly area, so for the assessment of the waist circumference. So the history is very important to assess the patients. The family history of the patient, drug and the alcohol history, and the next is the examination. The BMI, waist circumference, and then the investigations are fasting lipid profiles, LFTs, HbA1c, ultrasound abdomen. So there's no clue in these. Then you should proceed for the other investigation to rule out the secondary causes like a ferritin, transferrin, or celiac disease, thyroid diseases, the polycystic ovarian disease, or other liver diseases. That's like autoimmunes or the Wilson disease. So liver biopsy is a diagnostic test, but but the latest advancements, or there's elastography, we can help to make a diagnosis before going to the liver biopsy. So according to the American Diabetes Association, so patient with pre-diabetes or type 2 diabetes, you should be evaluated. If ALT or ultrasound abnormal, then go for a MR elastography. If this is a high risk, intermediate, or the low. If this is intermediate, then you should go for the liver biopsy to confirm this is a NASH. Or if the absence of the NASH, then you should re-evaluate or follow. But with the ALT or ultrasound is normal, then you should go for to assess the type 2 diabetes assessment is greater than 10 years. There is HbA1c greater than 8.5, TG greater than 250 milligram, or genetic testing. And then go for a elastography. So this is the criteria how to assess those patients with the diabetes with the normal ALT or with the abnormal ALT. So the studies has been done according to American Diabetes Association, which shows the prevalence of this disease is more in diabetes as compared to the general population. So this is data shows that the different criteria has been used, the ALT assessment, CT of the liver ultrasounds, or the other criteria. Similarly, the overall prevalence of the advanced fibrosis still shows this is more in the background of the diabetes. So diabetes is the one the condition which aggravate the fatty liver disease. There are some guidelines which shows that we focus on the lifestyle modification. Recommended foods, and these are the activities, which is avoid the junk foods or enhance that to take the parameters show that we should enhance to take the green vegetables or the fruits in the diet, or avoid to use the alcohol or this is a fructose containing diets, and similarly focus on the lifestyle modification in the form of the exercise, avoid the sedentary lifestyle. So calories restriction 500 to 1000 milligram per 1000 per day, 7 to 10% weight loss target, long-term maintenance approach, coffee consumption, and macronutrients composition should be in the diet. Avoid to take fructose or daily alcohol intake. Physical activities 150 to 300 minutes per week. So this is no definite treatment for this disease, but this is a lifestyle modification or the cause of the disease should be managed. So these are different types of the drugs has been introduced in the market, but there's a graveyard is full of these failed drugs for the NASH. So these are some drugs for the treatment of the obesity to treat this condition. First line drugs are the orlistats, and this is the liraglutides, and now the second generation, the semaglutides, or the combination with the dual GIP-GLP receptor agonist has been launched in the market, and we are getting a good response in the diabetes treatment as well as with the obesity. So the patients with having a diabetes, you should start with the pioglitazones. That's a very good impact in with also rule out the comorbid conditions. And another antioxidant is we can use the vitamin E. So pioglitazones have some side effects. We should be careful starting these drugs. If the patient is gaining the weight 2 to 4, or there is an edema, or there is a chronic heart failure, then should avoid to use this drug. So there is some drugs which have been introduced in or there's a pipeline, or these are the phase 2 trial has been done in these drugs. We are using the semaglutides. These are GLP-1s. But these have no improvement in the cirrhosis, but this is a impact in the weight reduction. So another drug is that this is a resmetirom. This this is in the phase 2 trial, and the opticolic acid. So lenifibranor. So efruxifermin. So according to the American Diabetes Data Association, so these are the different staging according to histologically, which shows there's an improvement with the use of these drugs. These are the alpha-beta-nor or the opticolic acid, liraglutides, vitamin E, and the pioglitazones. So efficacy for weight loss, pharmacological approach to treat the diabetes-associated fatty liver. So the first very high, the semaglutide, the high liraglutides, and the intermediate with the sodium glucose co-transport inhibitors. So those patients are not responding to the treatments and they're still obese. According to the criteria, the BMI more than 35, then you should go for a bariatric surgery. And those patients which suffer from this non-alcoholic fatty liver disease, the treatment is liver transplantation. So these convert into the NASH very actively, and this is a cirrhosis within the 7 years. So this is all about the alcoholic fat. This is the metabolic dysfunction associated fatty liver disease. Thank you very much.